So first, we have Dr. George Koshi sir coming up with a presentation on diagnosis and management of heart failure in diabetics. Dr. George Koshi requires no introduction in Kerala. So in Nagarkoil, sir has retired as professor from Trivandrum Medical College in the Department of Cardiology. Sir was retired as HOD. And one of the most important points about his career is that the governors of Kerala has had the privilege of having Koshi sir as their honorary cardiologist for several years. So I think that is a great position to occupy, and I think the governors have been very happy with sir to have them as their honorary cardiologist. Sir is presently working as a senior consultant in Cosmopolitan Hospital after his retirement. So I invite sir for the next presentation.
Let us start with a clinical scenario. A prototype Indian patient, an elderly lady, obese, multiple risk factors, presenting with increasing breathlessness on exertion for the last 6 months, on metformin, glimepiride, and for hypertension, telmisartan, amlodipine, and diuretic, also on statin treatment. The laboratory investigations revealed CKD with moderate grade albuminuria. The striking thing is the NT-proBNP, which is 840 picogram, and echocardiography revealed fairly normal ejection fraction. The LVEF is 58%. Along with that, you find a non-dilated LV with left ventricular hypertrophy, a dilated left atrium, evidence of diastolic dysfunction, and a TR jet of 3.4. Upper limit of normal will be 2.8. And obviously, this patient has heart failure, but normal ejection fraction. This is not very uncommon in a diabetic. And this is the entity of heart failure with preserved ejection fraction, which we are increasingly recognizing. And this is going to be a very major problem in the years to come. And what exactly is the problem? The problem is with the interstitium. And this does not happen overnight. This is not an acute MI developing heart failure. This is a gradual transition from normal to abnormal. You have normal diastolic function, diastolic dysfunction, increasing grade, and then heart failure with preserved ejection fraction. So this is what really happened. This is the normal shown here, and this is the abnormal which is shown there. The cavity size is small. That is the important point. Along with that, you have left ventricular hypertrophy very often, that collagen deposition shown there, fibroblast activation, interstitial and perivascular reactive fibrosis, increase in the stiffness, inflammation, endothelial dysfunction, capillary rarefaction. So all these things contribute to heart failure with preserved ejection fraction. So the important thing is small ventricle, thick ventricle, dilated atrium with all the other abnormalities in the interstitium and perivascular fibrosis. The phenotype is different. We are all familiar with the heart failure with reduced ejection fraction, which we discuss always. And this entity is the heart failure with preserved ejection fraction. We know the reduced ejection fraction, very often you find young males, post-MI, and they could be having risk factors. Many are diabetic or hypertensive. But when it comes to heart failure with preserved ejection fraction, the specific phenotype, very many times elderly females who are obese. So obese, elderly females. A combination of these risk factors in an elderly obese diabetic, always think that the patient could be having heart failure with preserved ejection fraction, and the cause for dyspnea on exertion could exactly be pointed to that. And it is not all that uncommon. If you look at the prevalence of undiagnosed heart failure in 60 plus age group in type 2 diabetes, heart failure with preserved ejection fraction is far more commoner than reduced ejection fraction. If you go by the strict criteria, it is almost 23%, very high. All the 23% may not be having true heart failure, but please do understand that they have dyspnea on exertion. The NT-proBNP is elevated, and if you look at the diastolic parameters, they are abnormal. And there's striking difference between males and females. In males, it is only 18%, whereas in females, it is 28%. So elderly female who is obese with type 2 diabetes is the phenotype. Prevalence of unknown heart failure with preserved ejection fraction and reduced ejection fraction in relation to the age. As age advances, that green bar is preserved ejection fraction, HFpEF. So above the age of 80 years, HFpEF is around 37.5%, whereas reduced ejection fraction is hardly 20% or 30% of that. So diagnosis of heart failure with preserved ejection fraction. We should understand that the pulmonary capillary wedge pressure, which reflects the LA pressure, may be normal at rest. But when you exercise the patient, there's a significant increase in the pulmonary capillary wedge pressure, and the patient experiences dyspnea on exertion. That is all you find in the initial stage. But later, as the diastolic dysfunction increases, they later come with significant symptom and may require hospitalization. At the time, you will have the elevated JVP, third sound, fourth heart sound, chest exercise showing all the classic features of pulmonary venous congestion, diastolic dysfunction, the dilated IVC, and all those things. But we should be able to pick up the disease at this stage, not after the full-blown feature when they develop heart failure. How do you diagnose heart failure with preserved ejection fraction? Signs and symptoms, very important, the biomarkers, the NT-proBNP. Normal NT-proBNP in a young person will be below 125. It tends to increase with age. In people in sinus rhythm, a value above 220 is supposed to be abnormal. In atrial fibrillation, a value above 600 is supposed to be abnormal. For all practical purposes, you can remember as 300 in sinus rhythm and 600 in atrial fibrillation. And that should be supported by the echo Doppler findings of dilated LA, left ventricular hypertrophy, structural abnormalities, and various diastolic dysfunction, especially based on the tissue Doppler and other things. And this is a scoring system which is very useful. The H2PEF score, and the points are shown there. And two important things, one is obesity. The second one is atrial fibrillation. Those are the things which are given maximum score. If the score is more than 6 or equal to 6, there is a high probability of heart failure with preserved ejection fraction. So next time, type 2 diabetic patient, elderly, obese, in atrial fibrillation and this comorbid condition, consider heart failure with preserved ejection fraction. And this is even more helpful. The HFA PEFF score, in which you have functional, morphological, and biomarker. Combining all the three, you have major criteria and minor criteria. I am not going into the details due to lack of time. This is readily available. And the Doppler assessment is very important. You don't have to look at each of those two things, but particularly important will be the left atrial volume index. The left atrial volume index. And the other important thing will be you look at the tissue Doppler, you look at the septal E prime. Septal E prime less than 7. Lateral wall E prime less than 10. So remember those two things, 7 and 10. And the average E by E prime, septal and lateral, more than 15. Or the TR velocity exceeding 2.8. These are some of the values which we can remember. And another important practical point, there is a relation between obesity and the natriuretic peptide. People with high BMI, the NT-proBNP tend to be less. So people with BMI 35, you expect the NT-proBNP to be 700, but in reality, it may be only 450. So you should give a correction for that in people with higher BMI, and that is exactly what is shown there. there's a BMI of 20. So when the BMI becomes 35, you look at its point, the NT-proBNP tend to comes down. So higher BMI is associated with lower BNP and NT-proBNP. Now coming to the management of HFpEF. Confirm the diagnosis of HFpEF. SGLT2 inhibitor is a primary drug. If volume overload, small dose loop diuretic with MRA. But excessive diuresis, you should be careful because already the preload is less and it can reduce the cardiac output. ARNI is useful, especially the EF is close to 50%. Target BP will be below 130 by 80. Correct the iron deficiency. Try to maintain the patient in sinus rhythm. And diabetes should be treated with SGLT2 inhibitor, GLP-1 analog and metformin to the extent possible. Evaluate for CAD, CKD, OSA, very important, and COPD. Those are the comorbid conditions. This we are all familiar, the dapagliflozin trial, the DELIVER trial, heart failure with preserved ejection fraction. 1/3 of patients had EF above 60, 50 to 60, and 40 to 50. So we have all the spectrum available. The average NT-proBNP was more than 1,000. We find there was a benefit. When you take the composite endpoint of cardiovascular mortality, hospitalization for heart failure, or urgent heart failure visit, there was a significant difference with a significant p-value. The point is, it was evident very early. So if you start treating HFpEF with SGLT2 inhibitor, you can find a benefit at the end of 2 weeks, and that is very remarkable. And the other beauty is that you take the different groups, even people with ejection fraction more than 60%, there was a significant benefit. There's a 22% reduction. So the benefit is there in all the ejection fraction groups. We have similar data with empagliflozin in the EMPEROR PRESERVE trial. Empagliflozin 10 milligram, again showing that the HFpEF, there is a significant reduction in the mortality, and the number needed to treat is 42. The absolute risk reduction is 17% when you take the composite of cardiovascular death or hospitalization for heart failure. Now we have some data with the ARBs earlier. We have data with spironolactone also, irbesartan, perindopril, candesartan. One of the first trial, the CHARM trial, showed some trend in the towards the improvement. The TOPCAT trial, the spironolactone trial, was almost a positive trial with spironolactone in HFpEF. If you exclude the patients who were recruited from Russia, actually there was a benefit in HFpEF patients. And the Paragon HF trial, though we consider it as a negative trial, it is not exactly a negative trial. The ARNI, there was a 13% reduction. Look at the confidence interval, 0.75 to 1.01. If this value was 0.99, it would have reached statistical significance. So there is certainly a trend towards better outcome with the ARNI in HFpEF. That is the Paragon HF trial. Look at the p-value, 0.06. If it was less than 0.05, it would have been statistically significant. So ARNI is certainly useful in HFpEF, especially when the ejection fraction is a little lower. It may not be very useful in people with ejection fraction 60%, but certainly it could be useful in people with ejection fraction in the range of 45 to 50 or 50 to 52. Now the new entrant is the GLP-1 analog, semaglutide. We have the data in HFpEF, September 2023, a small trial, 539 patients with BMI more than 30. Semaglutide, 2.4 milligram versus placebo given for 52 weeks. There was a benefit, especially the quality of life, the percentage change in the body weight, the 6-minute walk distance, and the inflammatory marker, the C-reactive protein. Change in body weight, everyone knows, was very considerable with the GLP-1 analog semaglutide. And for that indication, it is very extensively used now. Look at the p-value, which is highly significant. And even the reduction in CRP was significant, reduction in the inflammatory marker. And this is the new drug which we are going to get soon, the combined GLP-1 receptor agonist, the tirzepatide, which probably the trials are going on to find out whether it is going to be useful or not. This is a new trial with the Finrenon, the Fine Arts HF trial, initiated now. This is a recent ESC journal, May 2024. The study has been started, and there's a lot of interest in the non-steroid MRA. Because you look at the steroid MRA, spironolactone, the TopCat trial, it was found to be useful in HFpEF. If you have a subgroup analysis, excluding the Russian patients, it did reach statistical significance. Spironolactone is a useful drug in HFpEF. So the non-steroid drug Finrenon probably is going to be emerging as a useful drug. And before I conclude, something about the heart failure with reduced ejection fraction, the 4 pillars, which we are all very familiar, and the diuretic depending upon the requirement, the ARNI, the beta blocker, MRA, and the SGLT2 inhibitor. And for worsening heart failure, we have vericiguat, though it is still not a pillar. But the point is, for heart failure with preserved and mildly reduced ejection fraction, the only drug with proven value is the SGLT2 inhibitor. All others, are actually 2B indication, indicating that they could be useful, but not a very strong indication. And we should always remember that if you combine an ARNI with a beta blocker, with MRA with SGLT2 inhibitor, you can have a substantial reduction in mortality in heart failure with reduced ejection fraction. The mortality reduction is 64%. So 64% reduction in mortality with pharmacological treatment alone. And the sequencing, all that we know, I'm not going into the details. When you have the dry patient, clear lung field, tachycardia, ectopics, beta blocker first. Wet with hypertension, good renal function, it should be ARNI first. But a patient with borderline blood pressure, borderline RFT, borderline potassium, SGLT2 first. So depending upon the patient profile, you can decide. And beyond the pharmacological treatment, you have to listen to Dr. Natarajan. 2 important things, the ICD and the CRT. In both, that green is indicative of ischemic etiology. The indication becomes stronger when it is ischemic than non-ischemic. So the strongest indication for CRT will be ischemic etiology, very wide QRS, left bundle branch block. Whereas non-ischemic etiology, less wide QRS, non-left bundle branch block intraventricular conduction abnormality may not be a candidate for CRT. Then ICD depending upon the ejection fraction for primary prevention. But we should remember this is a continuum. Reduced ejection fraction, mildly reduced, and HFpEF. It's a continuum. But we have the SGLT2 inhibitor, which is effective with the entire spectrum of heart failure. That is why Braunwald mentioned SGLT2 inhibitor as the statin of the 21st century. So I think we should not wait too long. We should evaluate people with heart failure and people with type 2 diabetes, try to find out whether they are developing diastolic dysfunction. And SGLT2 inhibitors should be introduced early in the history of the disease. Because when you diagnose real heart failure, it may be too late. So as you tell about statin, when the next type 2 diabetic patient comes to you, and if you are not prescribing an SGLT2 inhibitor, you should be clear why you are not prescribing. As you tell about statin, diabetics should be on a statin. If you are not prescribing statin, you ask the question why you are not prescribing a statin. Similarly, when a type 2 diabetic patient comes, especially obese, elderly female, you ask why you are not prescribing an SGLT2 inhibitor. You could be having a compelling reason like UTI or something like that. That's a different thing altogether. Thank you very much.
Thank you, sir. I think sir has done justice to his topic. I think sir has presented the importance of heart failure with normal ejection fraction, or what we call the preserved ejection fraction, because the majority of physicians think that a patient can have heart failure only if the ejection fraction is low. The sir has clearly pointed out that there is something called medium reduced ejection fraction, and even the EF can be more than 60% for a patient who presents with symptoms of genuine cardiac failure. Sir has presented the topic very clearly and also highlighted the important drugs to be started. Any questions?
Reduced ejection fraction, traditionally we restrict fluids, but when you add SGLT inhibitor, gliflozins, so what is your recommendation because of urinary tract?
And I think that's very important because one issue is when you give a SGLT2 inhibitor, it also has a diuretic effect. Especially in the elderly, you should reduce the dose of the diuretic which they are taking and then introduce the SGLT2 inhibitor. That's very important. And if you are treating a patient with heart failure with preserved ejection fraction, in HFpEF, the end-diastolic volume is already less. They have small volumes. The stroke volume is less because the ventricular volumes are less. So depletion of the preload will further reduce the cardiac output. So before you start a SGLT2 inhibitor, it is very important to reduce the dose of diuretic. It is important both in the acute setting as well as in the chronic setting.
Okay.
So thank you very much.
Okay, thanks,
Thank you.
sir. Thanks.